Okay, I hope you can see my presentation.
Yes, we can.
Okay, thank you. Hello everybody once again. I would like to provide some information, quite initial information on pharmacoeconomic issues, which are also in focus of ENOTA working groups, especially we focus on pharmacoeconomics in working group 4. And I would like to provide some pretty basic information on what is a role and what is an objective of pharmacoeconomic analysis and why it's introduced in our ENOTA action as well. Pharmacoeconomic analysis is a method how to identify or measure or compare costs and clinical benefits and risks. For example, adverse events in case of programs, services of or therapies, which alternatives, clinical alternatives produce the best outcome for the resources invested. So thanks to pharmacoeconomic analysis, we would like to choose the best available, for example, therapeutic option for a patient to provide the most effect for the least costs, we can say. Pharmacoeconomics is also an interdisciplinary science in the field of health economics, the aim of which is to assess a relative clinical and economical value of medical technologies. The most often they are drugs, pharmacotherapies, or, for example, biologic therapy. In pharmacoeconomic analysis, you have always to compare both clinical and financial, economical outcomes related to pharmacotherapy, for example, with various pharmacotherapies. And in pharmacoeconomic analysis, you always have to compare your pharmacotherapy, which you would like to assess with something. You have to compare with another pharmacotherapy, for example, or you have to compare in case of no another pharmacotherapy for a condition is available. You have to compare your new pharmacotherapy with placebo or the best standard care. So this is the basic information that there is always a comparison of your way of patient treatment with something else, with another mode of treatment. And there are two general issues you have to compare. Clinical effect, so you have to measure incremental effect, so the difference in clinical effects between the pharmacotherapy you would like to evaluate and the reference you have chosen for the comparison. And also you have to compare costs of your pharmacotherapy evaluated with the comparator, with the reference mode of therapy, for example. So in pharmacoeconomic analysis, you have to calculate what is incremental cost, so difference in costs between the, for example, two pharmacotherapies, and what is incremental effect, difference in clinical effects. When you got this information, when you got these digits on incremental cost and incremental effect, you could calculate marginal cost. Marginal cost is an incremental cost divided by incremental effect. And in other words, the marginal cost is an information how much you have to pay if you would like to get an additional unit of clinical effect, when you compare the more effective therapy with a least effective therapy. So this is a core, this is a focus of pharmacoeconomic analysis. We have four main pharmacoeconomic techniques we can use for these calculations. The most important and the most popular, the most often used one is cost utility analysis. And cost effectiveness analysis is also often in use, but it's not so informative as in case of cost utility analysis. And then I will tell you why. Sometimes also cost minimalization analysis is also used in decision making in pharmacoeconomics. And the least often used pharmacoeconomic analytical technique is cost consequences analysis, which you use quite rarely. And how to choose the proper pharmacoeconomic method to make the relevant calculations during pharmacoeconomic assessment. The beginning of everything is a systematic review of clinical evidence. Before pharmacoeconomic analysis, a systematic review of clinical evidence should be performed. And based on results of this systematic review, based on comparison of efficacy and safety profile between the intervention and comparator or comparators, you have to choose analytical technique in further step. In case the assessment of efficacy and safety profile would provide information that there is a difference, significant difference between intervention and comparator, you have to use cost effectiveness analysis or cost utility analysis. In case of evidence in case of lack of evidence that there is a significant difference between intervention evaluated and comparator, you have to use cost minimalization analysis. So you have no evidence there is a significant difference, significant clinical difference between the two treatment options, and in such case you have to use cost minimalization analysis in further step. And cost utility analysis and cost effectiveness analysis takes into consideration both costs and health effects, which are provided by intervention and comparator or comparators. In case of cost minimalization analysis, only costs are considered because based on systematic review, we knew that there is no significant difference in clinical effects between our intervention and comparator or comparators. So we take into consideration only costs of the two treatment options. Cost utility analysis we can use when we have an evidence that there is a significant difference between our intervention and comparator in terms of clinical effectiveness or safety. And a measure of health outcome in case of this analytical technique is quality adjusted life year. Quality adjusted life year is a year of life in a premium 100% quality of life. So this is the best available quality of life, and 365 days of such a life with maximum best available quality of life is just a quality. And in cost utility analysis, the most informative sort of pharmacoeconomic analysis, the results are presented as marginal cost associated with one additional quality for comparison of our intervention and comparator. So we calculate within the analytical technique how much we have to pay to get one additional quality if we compare more effective therapy with least effective therapy. And in cost utility analysis, we have to calculate incremental cost utility ratio. It's a marginal cost providing us information how much we have to pay to get an additional quality. In case we use better clinically therapy in place of worse clinically therapy. And at the conclusion of the cost utility analysis, we obtain an ICER value. So we obtain a value of incremental cost utility ratio. And this value is very informative for decision makers because we can evaluate the ICER value in relation to GDP per capita. And the threshold value for cost effectiveness of drugs in comparison with comparators is 3 times GDP per capita. So in case we got an information, we got a value of incremental cost utility ratio below the threshold value, so below the value of 3 times GDP per capita, we can say that the intervention is cost effective compared to the specified comparator. And if the cost utility analysis result presented as incremental cost utility ratio is higher than the threshold value, 3 times GDP per capita, we can say that intervention is not cost effective compared to the specified comparator. And this way of use of cost utility analysis result is very friendly for decision makers because they have a threshold value. And that's why they can make quite simple decisions. For example, for reimbursement, if they got a result of cost utility analysis and they know what is a threshold value of incremental cost utility ratio in their country this year. For example, in Poland is 190,000 zlotys. It's about 45,000 euros per quality. So if we got a result of cost utility analysis below the threshold, we can say it's cost effective. But if we got the result higher than the threshold, higher than 45,000 euro per quality, we can say it's not cost effective. So price of drug should be decreased to get result of incremental cost utility ratio below the threshold. So we can say that unit of measuring effects in the case of cost utility analysis is quality, and cost of measurement unit is just a monetary unit. In case of cost effectiveness analysis, we do quite similar calculations, but we calculate additional cost, so marginal cost per one live year gained or per natural unit. So we also calculate in cost effectiveness analysis marginal cost. It's called incremental cost effectiveness ratio, ICER. And this ICER is incremental cost divided by incremental effect presented as incremental live years gained or incremental natural units. Natural units, we mean, for example, years of life, events such as cardiac arrests or strokes, or natural unit is also mortality, death. So we can use a variety of natural units to calculate what is ICER in comparison of two options of patient's treatment. This parameter is less informative because for decision makers, because we have no threshold value, as in case of cost utility. That's why cost utility analysis is more friendly and more effective for decision makers. And that's why decision makers, for example, in case of reimbursement cases, mainly based on cost utility analysis, and cost effectiveness analysis is just an additional analysis on the second plan, and just as additional option providing some additional information, but cost utility analysis is a main factor influencing decision making. And cost minimalization analysis is performed when we have an evidence there is no clinical difference, no significant difference between two therapeutic, for example, options compared, or in case we have no evidence that there is significant difference between the two options. So we can presume that clinical effect of both therapeutic options are equal, they are equivalent. So the result of cost minimalization analysis is called incremental cost. So that's just a difference between cost of drug option A and drug option B, for example. Or it's a comparison between strategy with TDM and strategy without TDM. And in such a case, we can also make relevant calculations, but we have to base on conclusion from clinical effectiveness assessment that there is no evidence that there is a significant difference between the compared therapeutic options. And what are the main conclusions from the pharmacoeconomic analysis? We can conclude that strategy A is cost effective compared to strategy B, but we can say it in case marginal cost ICUR is below 3 times GDP per capita threshold. We can say that strategy A is cost saving compared to strategy B when there is no significant difference in clinical outcomes between the two options, and strategy A is cheaper than strategy B. And also conclusion from pharmacoeconomic analysis could be that, for example, strategy A is dominant over comparator, is over strategy B. And we can say that strategy A dominates over its comparator when it's clinically better, so provides significantly higher clinical effect, but also it's cheaper than comparator. So this is the most favorable situation for the intervention compared with comparator. Okay, and we have now I would like to present some examples of pharmacoeconomic analyses which were performed within two TDM, and the first example would be by Gomez Arango, and in this case, in this example, cost effectiveness of TDM of adalimumab in therapy of 3 rheumatoid diseases was performed. So TDM strategy was compared with no TDM strategy in case of adalimumab therapy. Quality adjusted life years were evaluated here. But also some clinically relevant outcomes, such as number of persistent and overall flares, time to first flare, and days with high disease activity were also taken into consideration. In case of cost, only direct medical costs were considered. In this pharmacoeconomic analysis, it occurred that a number of flares was lower in the intervention group, but there was no statistically significant difference between TDM and no TDM strategy. But overall quality of life was significantly improved by TDM strategy compared to no TDM strategy. So authors could conclude that in case of these diseases, in case of these conditions which were considered, TDM strategy occurred effective and significantly improved quality of life, but at the same time, this TDM strategy provides also savings in terms of costs, in terms of money. So we can say that in this pharmacoeconomic analysis, TDM occurred dominant over no TDM strategy. Another example would be on analysis by Ukar, who performed his analysis for 3 different rheumatic diseases, and patients in this study, this pharmacoclinical, as well as in the same time pharmacoeconomic study, were divided into a control group without TDM and intervention group with TDM. When the clinical trial and pharmacoeconomic trial was concluded, it occurred that clinical outcomes were significantly better in case of TDM strategy group. So we can say that there was an observation of improved quality of life of patients in intervention group with TDM. And in the same time, the costs generated by TDM strategy were lower than costs generated in the control group. So also we can say, based on results of this example of pharmacoeconomic analysis, that TDM occurred dominant over no TDM strategy. The two presented examples were pharmacoeconomic analyses which were performed in case of simple clinical trials, but also in literature databases there are available some some publications related to meta-analysis of some pharmacoeconomic analyses which were performed worldwide. And now I would like to present an example of such meta-analysis of 14 studies, 8 RCTs and 6 cohort studies involving more than 2,400 patients, which aggregates data from clinical trials related to comparison of TDM-guided anti-TNF therapy in comparison to no TDM anti-TNF therapy. So TDM-guided therapy was compared to empirical guided therapy. In this meta-analysis, for some clinical outcomes, aggregated clinical outcomes occurred significantly better for TDM strategy, but not for all the clinical outcomes. The differences occurred significantly different. In case of clinical remission rates, for example, which is very important clinical outcome, there was no significant difference between TDM and no TDM strategy. But for some other, we can say maybe less important clinical outcomes, the significant difference was observed. For example, low disease activity rates were significantly lower in case of TDM group. Based on result of this meta-analysis, we can say that no significant difference was observed in case of disease activity score, mean disease activity score, radiographic progression, and safety. But TDM-guided therapy performed in the meta-analysis revealed that although there was no significant difference in a variety of clinical outcomes, the TDM strategy was better because it reduced cost per patient per year, calculated as the total accumulated sum of therapy costs. So although there was no significant difference favoring TDM strategy for a variety of clinical outcomes, it occurred that TDM-guided therapy is significantly cheaper than no TDM therapy. So in case of this meta-analysis, we can conclude that although no significant clinical higher effect of TDM guided therapy, in case of cost assessment, it occurred significantly cheaper than no TDM therapy.
Paweł, I guess, sorry to interrupt you, but I think we have to move on.
Yes, of course.
To
And
let Isabelle
the last
Huys.
slide. Yes, the last slide, that cost effectiveness analysis, which were found during the review of available evidence, provided information that TDM strategy in various pharmacoeconomic analysis is at or cost effective or cost saving or even dominant over no TDM strategies. So these conclusions are pretty favorable for TDM strategy in biologic treatment of inflammatory diseases. Thank you.
Thank you
Thank
very
you,
much,
Paweł.
Paweł, for your very nice presentation. Also, it's very nice to see some example related to the TDM application. So that's really nice.
I think
So
we are very nicely equipped to understand all what it is about cost effectiveness, cost utility, and this is really a nice presentation, Paweł.
Thank you very much.
Maybe we can ask, we can go for the Q&A after Isabelle's presentation.
that sounds very good. Then I would like to introduce the second speaker of this webinar today, and that is Professor Isabelle Huys. She is a full professor at the Faculty of Pharmaceutical Sciences at KU Leuven. She is heading the unit of pharmacology and pharmacotherapy. She is leading several projects in the group of regulatory sciences. Her research focuses on optimizing market access of medicines to patients by improving pathways for medicines development up to regulatory approval, health technology assessment, reimbursement, and also the clinical adoption. And her scientific research is directed to patient preferences methods, and that will also be the topic of the presentation today. And she uses both qualitative and quantitative techniques, and she do research focusing on the implementation strategies into medical decision making. So with that, I would leave the word to you.
Thank you, Elisabeth, for this nice introduction. And I will share again my screen. So indeed, today I will talk to you about patient preferences in chronic diseases. And as we have now already talked about economic analysis and cost of utility analysis and cost effective analysis and so forth, I want to introduce you to another area which is actually related to that and is actually related to how can we bring in the voice of the patients and how can we actually measure what really matters to patients from their point of view. Patient preference studies are indeed a methodology to investigate what is really important to patients. And here I present to you a definition that has been elaborated by the FDA, the Medicines Agency in Europe and the US, giving a definition of a patient preference study that investigates the relative acceptability to patients of choices that they need to make about the outcomes of different health interventions. And these outcomes are characterized by particular attributes. You can call them characteristics. So what are patients ready to accept in terms of outcomes that are presented to them, and how do the different characteristics of these interventions relate to their preference? So indeed, patient preference studies are methodologies to investigate what treatment characteristics or what disease characteristics matter to patients. Also, how much are patients valuing a particular disease characteristic or a particular treatment characteristic? Think of a benefit that is associated with the treatment or a particular side effect. How worse is it for patients actually when you measure it, for instance, from a clinical trial? As well as how are patients trading off the different benefits and the risks? Which risks are patients ready to accept in terms of in return for what amount of benefits related to a particular treatment? And how is this outcome or these preferences of patients changing in terms of the particular characteristics that patients may have in terms of where they live, what age they have, in terms of their treatment experiences that they have had in the past. And I will give you an example for the disease, namely alopecia areata, that is characterized by hair loss at the scalp or hair loss at eyelashes. That impacts a lot the quality of the life of these patients. And luckily, recently, there has been a new therapy that actually may address and may reduce and even avoid hair loss at the scalp, but comes along with particular severe risks, safety effects, namely the risks for developing blood clots or risks for developing cancer. And patient preference studies may inform us how much benefits in terms of reduced hair loss patients accept in order to accept a particular risk of developing, for instance, blood clots. And also whether that outcome will differ depending on the type of person that you have in front of you, namely, is this different between men or women? So such a patient preference study really starts from the patient. It is a qualitative study where you talk with patients either alone, individually, via interviews or in focus group discussions in a very structured way, where patients are able to express all aspects that they think about related to their disease and related to their treatment. And this is actually a basis to take the next step in a methodology, namely to develop and select certain attributes, particular characteristics that we use as a basis to quantify further in a survey. So this survey is actually a quantitative methodology in order to give a weight on the benefits or on the risks that patients perceive or are ready to accept. And is this something wishful thinking? Is this something just purely at the research stage? No. Such patient preference studies are nowadays more and more taken into account by European regulators, by HTA agencies or payers. And here I show you the example of the drug ritlectinib that was developed for alopecia areata, and whereby the EMA, European Medicines Agency assessors considered the patient preference study in order to inform their benefit-risk trade-off that they always do when they assess medicines. And this patient preference study was actually based on a discrete choice experiment, and that was applied to the outcomes of the clinical trial results. So in the clinical trial, there were indeed certain outcomes, primary outcomes, secondary outcomes, benefits, risks, and so forth. And based on the patient preference study, the maximum acceptable risk of potential severe safety concerns, think of these risks to develop blood clots or risk to develop cancer, were assessed, and it was calculated, and that was associated with the JAK inhibitors, and it was assessed in order to investigate what acceptable risk are patients willing to take to tolerate particular benefits, and also to calculate the net benefit risk profile. And given the value, the high value actually that patients wanted to give to this scalp hair regrow, actually, this medicine received a positive CHMP opinion, which in the end resulted in the marketing authorization of this drug. So this technique of patient preference studies has been standardized nowadays. I was participating in a large IMI consortium, which is a public-private partnership, where we developed the whole strategy and methodology for patient preference studies. And we presented this to the European Medicines Agency, who provided a positive qualification opinion for these methodologies. And in the meantime, we conducted a lot of patient preference studies based on this methodology. And nowadays, we are also collaborating and actually interacting with the European Medicines Agency, also to develop an international ICH guideline on patient preference studies in order to inform scientists, but also industry and so forth, and European regulators about this type of studies. To give you an example of a patient preference study in inflammatory bowel disease, I will present the results of a European survey we conducted in this area in the discrete choice experiment. It is actually the PhD of Elise Huys, who also prepared these slides for me. And I am the promoter of this study. And the study is still ongoing. Why a patient preference study in IBD? There are multiple treatments for IBD patients in development and also in use. And depending on the different characteristics, patients may accept or not these different treatment characteristics. So our aim was to quantify the patients' preferences for these treatment and disease-related characteristics, and actually to determine the relative preference weights for these IBD treatments and disease attributes, and also to determine whether that differs across patients. What is the patient heterogeneity, the preference heterogeneity? Is it influenced by the socio-demographic characteristics of these patients or other contextual factors? We didn't do this study alone. It was a very unique collaboration with the European Federation of Crohn's and Ulcerative Colitis Association, and also in very close collaboration with the IBD clinicians here in our University Hospital Leuven and the Belgian Inflammatory Bowel Disease Research and Development Association of physicians. And in a very iterative project. So they were involved in all steps, and in the end we had 14 attributes or characteristics that were considered important to assess in this study. How did we do this? Via literature reviews, via focus group discussions, so bringing these patients together around the table in order to inform our survey. The survey itself is the following. So 14 attributes and also related levels of these attributes were used in order to design 15 discrete choice scenarios, questions if you want, that actually you see here at the right side. And so we presented these, we created 15 different scenarios where patients needed to choose between treatment A or treatment B. And whereby for each treatment, there are different, at the left side, you see different attributes. For instance, the risk to undergo surgery is in treatment A and treatment B the same, namely low. However, the severity of psychological impact of a particular treatment is moderate for treatment A and severe for treatment B. So this may indeed impact the choice of a patient, taking into account as well how the treatment is administered or also how fast the treatment works, in order for a patient to select for patient treatment A and B. This survey was actually initially developed in English. It was piloted in English, then afterwards translated in 15 languages in close collaboration with the patient organization, and then analyzed via a multinomial logic. Currently, the survey is still ongoing, but I show you the results from last November, whereby we had already 1,272 completed surveys from patients or from participants from 37 different countries. And what I can tell you already is that the main age was 42 years old, with patients coming from mainly from the Western Europe. The least is from the Northern Europe, and with patients that mainly were treated with biologicals and for a small part by molecules, but that was the least one. Which attributes were actually selected and raised by the patients? The most important ones are related to the severity of the abdominal pains and cramps, followed by the urgency and the pain of having to go to the toilet, and then afterwards the severity of the fatigue that they perceive as a consequence of their disease. I use also the wordings that the patients used within the interview, so that's extremely important. Attributes which were least important were related to the onset of the therapy, namely how fast the treatment works, or related to the way the treatment is administered, so the mode of administration, or also the endoscopic activity, namely the presence of visual signs of inflammation in the bowel. We also calculated the relative importance of each attribute level, and these results are presented as utilities. And as expected, since we have mainly negative attributes, as expected, these all had a negative sign, namely negatively compared to the null level of preference, and which means that actually these side effects really had a negative impact on the patient utility. And what we saw, that there are also significant predictors of a patient choice, namely the mode of administration or the onset or the endoscopic remission aspects were considered actually less important to patients, because these utilities, as you see here in the red, are very close to zero. However, other attributes such as So the biggest utilities, so to say, negative utilities are severe fatigue, severe abdominal pain and cramps, and the high urgency. These are really the aspects that patients dislike it the most. We also did an analysis across the regions in Europe. And I think here important to mention is that indeed, again, the mode of administration, either via patch or rectal or subcutaneous or intravenous, is actually not something which influences patients' choice much. However, what patients really value the most is the fatigue. What patients value the most in the Western countries is actually fatigue, and also the impact on their psychological well-being. So the psychological impact that patients value the most in the Western countries compared to the Eastern countries. So the analysis to the survey is still ongoing. We are performing for the moment further analysis, so there will be a lot of results coming out of this work. But what we can already say as an intermediate conclusion is that gastrointestinal problems are considered very important to IBD patients, next to quality of life attributes related to the physical and psychological aspects. And characteristics that really distinguish the difference in the treatments from each other. Think of these different ways of administration for these for the different medicines is considered less important to patients. And the observed differences in the preferences that we saw and that were revealed by the DCE that emphasize as well that it is very important to consider patient preferences also when treatments are selected, because if others select a treatment, that could take a completely different direction. So I want to thank actually my team, especially Elise Huys, who prepared these slides and also who worked a lot on this, who conducted this research as well in my research group. But I also wanted to thank all the collaborators in this study, in particular the EFCA, the patients organizations, the IBD group of UZ Leuven, and the BIRD group for the partnership in this study. Thank you.
Thank you very much, Isabelle, and thank you both for your excellent presentations. I do think we have some time for some Q&A sessions.
I can start. I was very impressed by your presentation, and one of the issues we are facing with our patient is the observance of the treatment. And some patients discontinue the treatment. It is not that rare that patients are not willing to keep with the treatment for some reason. And this is an important aspect. Have you tried to measure what is the driven, what drive the observance of the treatment, to adherence to the treatment? It is the route of administration. It is something like this.
Indeed. So as indeed the mode of administration is considered as less important for patients compared to the effect of the drug on their, whether they become fatigued or not. It's not that drives patients to stop a treatment. It's actually the way the treatment will solve their effects, will solve actually the urgency that they feel in order to go to the toilet, or for instance the severity for fatigue that they experience. I mean, you should imagine if you have such a disease, it's very you become very fatigued by just facing it every day. And if the treatment is not improving the therapy, not improving the situation, patients may indeed feel the treatment is not doing its work and we will stop. It's not just because of the mode of administration will now be a patch compared to another. Yeah, and I should be a little bit. I should be a little bit cautious, because this is a patient preference study, which is a quantification of patients across Europe. It's not an individual assessment. So for particular patients in a particular setting in the doctor cabinet, it still can be that one patient can say, you know, I prefer an oral administration versus a patch or whatever. Can be, and that for that particular patient, this is the most important thing. But in general, when we take it from a quantitative point of view, what patients value the most are the aspects that I have shown to you.
George has a question.
Yes, thank you. Thank you both for the presentations, and thanks to Elizabeth and Denis for the introductions. I was also very intrigued by your presentation, Isabelle, and you alluded to it a little bit in the beginning of your talk, the effect of biological sex when you mentioned men versus women. And I wanted to ask you whether you can elaborate on this and to add to the equation also gender, and particularly when we are considering now the ever-growing transgender population. Whether you have had any experiences with such patients at all, and whether any of the aspects that you have been studying might differ from cisgender individuals. And just to add one more thing in this very long equation, because you mentioned, of course, some of your studies are pan-European or European-wide. Do you see any differences also between, let's say, West and East or North and South? Thank you.
Yeah, I think it's a little bit too early to make, let's say, huge statements on this yet. And we will do this. We will dive more into depth about this. So the participation till now for with respect to genders is 30% for men and 66% for women. Which is actually in line also with the with the population division in the disease population itself. So that's therefore we will, that is already a good thing. But whether or not these preferences will change depending on the fact that we have here a woman or a man, that's actually something which we actually have not yet, for which I have not yet the results here in front of me, that we need to still to calculate. But you are right, it is difficult sometimes to take into account other types of gender. And in this case, we did men or women. We didn't include other or whatever. And I think this is something which is a very important domain of research that we nowadays need to do. And now, but this in our case, we made this decision. However, it is difficult to do this in order to have a quantifiable group that afterwards you could yeah. And I can imagine that some people could not fill it by asking them to choose for one or another. That's true. But yeah, what I present to you. So and I think we will definitely, let's say, dive deeper into that aspect, because it's extremely important. And I think indeed, when you listen to the patients and the burdens that they experience, indeed, it might be, yeah, it might impact on whether or not to get children or raise them and so forth, because it impacts a lot in a different way the life of patients that take care of children. But this is also not only related to men or women. So yeah, it's complicated. Yeah.
Well, I'm very intrigued by it, and my work is on sex and gender, of course, in the cardiovascular field, a little bit different, but still, if you need any contributions at all, I would be more than happy. We can take this, and it's legitimate to really disclose that you are focusing on biological sex. That's also legitimate. It's absolutely fine, because when you have distinguishing men versus women, it's biological sex, it's not gender. So you have a valid point there as well. So as I said, I'm very interested, but I just throw this out, and thanks again.
Yeah.
So in conclusion, Isabelle, you're most welcome to join Enota, of course. And
Yeah.
so before we close this, we adjourn this webinar. So I would like to thank Mehmet, who is not present here, who is in charge of the communication and is in charge of the website. He's doing a great job. And also Elizabeth and Erwin for this program, which is diverse and so rich. And so you open our eyes each time, each month, and that, yeah, it's really nice to have this this initiative, this webinar series. Elizabeth, you want to close the session?
Yeah, I just want to thank both speakers. Of course, it was a very excellent presentation. And I hope to see you in a month's time for the next webinar. Please register online. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.